Good morning, everyone. Good evening for some people from the States. Thank you very much for joining us today. I welcome you all to our KU Global Lecture Series focusing on data in the era of digital transformation, in which it is our task to reevaluate and, if necessary, reinvent this field of data science. 416 people who registered for this program are not only from Korean University, but also from other universities and institutes around the world, including United States, Japan, which was very exciting. And more importantly, participants in this program are from 65 different departments, which reflect the widest range of disciplines the data analytics are applied to. Today is the final lecture of the program. The last but not the least, it is my great pleasure to introduce our featured speaker, Professor Arash Shaban-Nejad. Professor Shaban-Nejad is Director of Population and Precision Health and Associate Professor in the Center for Biomedical Informatics at the University of Tennessee Health Science Center in Memphis, United States. Dr. Shaban-Nejad received his PhD in Computer Science and Concordia University, Montreal, Canada. His primary research interest is population health intelligence, precision medicine, epidemiologic surveillance, semantic analysis, and explainable medicine. His research has been supported by several research grants from Canada Institute for Health Research, National Institute of Health, NIH, and National Cancer Institute, and Gates Foundation, Microsoft Research, and Memphis Research Consortium. Very impressive list. That being said, it gives me great pleasure and pride to describe Professor Shaban-Nejad as my mentor. I partook of 3 years of postdoctoral fellowship in his lab, which was very fruitful. Today, I look very much forward to what Professor Shaban-Nejad will talk about with the title, Multimodal Data Fusion and Analytics to Improve Population Health, with a subtitle of Responsible AI Perspective. After his talk, Professor Jung Yu-jin from the Department of Linguistics at Korea University will open up for discussion. Please join me in welcoming Professor Arash Shaban-Nejad.
Thank you very much. Really nice introduction. Thank you all for inviting me for this exciting lecture series. And it's a pleasure and honor. And I'm very happy to be here. Hopefully, when things settle down, I can meet you all in person. Without further ado, I'm sharing my slides. Let's see if I can share my slides here. Can you all see my slides?
Yeah, can you actually make it as a full screen? Because we can see all the sidebar. Perfect, yes.
Okay, wonderful. Okay, hello everyone. So for the time of this presentation, I describe a little bit of the problem, and then I show you some of the theories and framework we are using. And at the end, I show some example system and some of the methods I describe in action. Well, I start with this map of global mortality. As you can see, this is a grim picture of human misery, if you want to call it. So you see different types of diseases with different colors. On your left, you see infectious diseases. On your right, you see in the pink chronic diseases, and in green injuries. And what it shows is actually shows the cost of and cost and burden of these diseases based on a measure we usually use and call it DALY, disability adjusted life years. And so the brighter color, means the darker color means higher cost of, for example, disease on society, and lighter color means lighter burden. So as you can see, for example, a stroke in the heart condition almost responsible for one. Okay. As you can see, heart disease and stroke actually responsible for pretty much quarter of this non-communicable diseases, chronic diseases, but the cost is not that high because usually it impacts people with older age. And if you look at the top leading causes of death in the US, actually, so the numbers come from the CDC statistic for 2020. So you can see the top 10 cause of death. So of course, heart disease and cancer are responsible for a big chunk of these mortalities. And COVID-19, it was kind of first time in the past couple of years that an infectious disease comes that high. Usually in developing countries, we used to see more like a chronic diseases on the top, and in developing countries, for example, in some countries in sub-Saharan Africa, we might see infectious diseases on the very top. But we have COVID this year and accident, so chronic lower respiratory diseases, and so on. And what's interesting in this list is many of these diseases has behavioral, social, economical, and environmental components. And if we want to be frank, probably we can put an arrow link to COVID-19 and other, for example, infectious conditions like influenza as well, because there are also some social condition involved in those diseases as well. And the good news is most of these social, behavioral, and economical factors are modifiable. So we hope by modifying this indicators, we can actually improve our population health. So talking about the social economic aspects, so probably most of you are familiar with the concept of social determinant of health. So these are mostly social and economic factors that collectively determine population health and well-being. And as you can see, we have education, we have clinical care, housing, social relationship, and social economic status, and education. And probably you have heard that the role of social, economic, and behavioral factor is pretty high. So this actually might not, this pie chart might not do the justice. Pretty much the genetic factor and clinical factors can cover almost 20% of individual health, and most of the overall health will depend on other social determinant of health. So as a public health expert and public health practitioner, people try to look into the population and collect data, track population through time and space, and analyze this data. Then using this analytics to design intervention. This intervention can be preventive or therapeutic, and then deliver this intervention to the population, and again, monitor the population, collect data, and back to the health system to evaluate the impact of intervention. This is pretty much a life cycle of public and population health surveillance we are looking at. And again, you might be familiar with the notion of precision medicine, which tell you the human health and disease can be treated with consideration of all the elements involved. So it's more like a holistic approach, looking at the interaction between genes, lifestyle, and environment. And so in order to fully use the capacity of precision medicine, we need to address so I divided them into seven pillars, which we call it like precision observation and assessment, health promotion, engagement, early detection, prevention, treatment, and equity. So there are different dimensions of precision population health. And so at the center of all this precision health medicine is the data. And this data coming from different resources. Each individual can produce a massive amount of data, and this data can be stored in different formats, in different modalities. And the thing is, we're not standalone creature. We're living in a society, and we actually play different roles. We are influencing our society. We are influenced by our peer, and we take different roles and responsibility, different activity. We belong to different social economic classes. And so as you can imagine, so we are talking about a very large volume of data set. And these data sets are volatile. They have high velocity, high volume, and they also have different varieties. And the key term in precision medicine is the concept of data sharing, how we can integrate this distributed data sources and make a meaningful decision and informed decision using this data analytics. Well, in order to design intervention, we usually need to understand the causal pathway of a disease. We need to know the origin of disease. Specifically, if we are talking about chronic diseases, most of them has a very complex causal pathway. And we really need to find data scattered all over the places, pull them, make them coherent, accessible into a central data repository, and make it accessible to the target users. So talking about the data, we're talking about all sorts of structured and unstructured data set. And some of this data are easier to link to individuals. Some of them are a little bit tricky, hard to map to individual. And some data set exists only at the aggregate level. So if you can look at this diagram, for example, from the top to the bottom, so you see, for example, medications, demographic encounters. So as you get to the middle of this chart, you see the data set with light blue. So these are some of the data set. We have a little bit difficulty mapping it to individual, but we can do that. As you go to the bottom of this list, you see the pink, for example, type of data, the census tract, the climate, weather, GIS maps, EPA information. So these are usually exist only at the aggregate level. And so the major challenges, as you can imagine, is first of all, the heterogeneity of data sources we are dealing with. And the problem of missing data. And so usually you are dealing with a lot of missing data in population health surveillance. And even when you have the data, they might not be at appropriate temporal or geographical resolution. And also many of this data set might not be a good representation of population of interest. Other challenges are, for example, the problem of interoperability between different, for example, data sources, between different devices, different, for example, communication protocol, network infrastructure. And so the data usually captured in different format, different representation language. And most importantly, they have differences in their semantics. And the semantic heterogeneity is one of the biggest challenge dealing with this kind of, for example, data set. So by semantic heterogeneity, I mean, like, for example, you have terms, different terms referring to one concept, or you have, for example, a similar concept talking about different, for example, contexts. This data set usually stored in different, for example, data sources in different formats and different modalities. So you have data stored in text, in numbers, stored in relational databases. There might be graphics, video, audio, and chart tables, and all sorts of things. And here, one of the biggest challenges start working with this data is integrating this data set into a uniform data repository. And usually combining this different data set to enable, for example, semantic inferencing and learning is one of the ultimate goal of data engineering at this level. So we call it multimodal data fusion. And the multimodality comes from the nature of data actually coming from different resources. So this type of data, you can for example, see some of them might come, for example, hospital electronic health records. Some of them might come from, for example, mobile data, some coming from claim data or medical providers. And we have genome registries, we have radiology lab, we have, for example, the pharmacy claims, and all sorts of sources. And again, back to the problem of interoperability, besides the foundational and the structural interoperability, we need to maintain between our data sources in order to create a consistent integrated data set. So we need also to maintain semantic interoperability between these data sets as well. So these are mostly the problems. And I'm going to start with the big picture of approach we're using for this, for example, tackling these problems. So the method we're using called health intelligence, we call it health intelligence, and it usually consists of 4 or 5 steps. And so we start with integrating a large volume of data set and consider, so these are the same data we talked earlier, suffering from all sorts of problems. And we usually use knowledge graph, ontology, semantic network to create a semantic backbone for this data set. And then we do a quantitative and qualitative analysis to find patterns within a structured and unstructured data set. And we use this analytics to generate exploratory and predictive models. And the type of intelligence we're using in this health intelligence framework is a specific type of AI called responsible AI. And by responsible is we mean we should have a good control of the whole output of our machine, our algorithm. So we want to make sure that the purpose put into the machine is the purpose which we really desire. And so there are some principles for responsible AI. One is fairness. It tells you AI system should treat all people fairly and equitably, and it should, we have human in the loop. It means it should empower and engage people, and talking about the accountability of people, because one key features of responsible AI is trustworthiness. So how we can trust this AI platform. So we really do not trust machine, but trust people. So people at the end of the day would be accountable for the outcomes. And of course, it should be done with taking into consideration all privacy and security measure, and it should be also explainable and understandable. So explainability is a big part of our framework. And so explainable artificial intelligence is a relatively new concept, and it tries to make the black box of, for example, machine learning methods more and more transparent. And just give you an example. This is a classic example. So on the top, we see, for example, a classic machine learning models. And at the bottom, we have a more explainable model. if you have a picture of a cat, so you can actually do some image segmentation. You can actually do some pattern matching, and with a certain accuracy, you can actually identify the image as a cat. On the bottom, so you do all of this calculation, but you also have a semantic network at the middle. And this actually semantic model creates explainability for the system. So when you identify this picture as a cat, you have justification. You say this is a cat because it has a fur, it has a whiskers and claws. It sounds like a cat, it walks like a cat, and it has, for example, certain other features. So you justify your finding. So it helps a decision maker to actually rely and trust on your result. And they can use, for example, your result for more informed decision making. And if we want to give an example of explainable AI versus responsible AI, some people usually use this classic example of, for example, plane crash. And when a plane crashes, people usually go search for black boxes. They decode the information, and using this information, they can find the reason and the cause of the crash. And using this data set, then so until now we have explainable model. We have explanation for the plane crash, and then we can use this explanation to train our pilot, to train our crew, to talk to our engineer, to modify, for example, certain parts of the plane to avoid this kind of accident happening in the future. So that would be more responsible approach, for example. So this is exactly what we want to do in our system. We want to give a heads up to our, for example, intelligent agent and help public health practitioner to use this, for example, recommendation coming from the system to make more informed and calculated decision. So this is pretty much the framework of a deep learning model with the addition of semantic network on the middle. So as a matter of fact, what we try to do here, we try to put the data into an appropriate context. So in this way, we make this data actionable. And so we use semantic network. And again, there is this example, consider two elements, two entities here. So I assume not many people here know Latin. So we don't know, for example, what's written here. But we can, for example, create an arrow from one to the other one and put a tag on this and call it place of birth, and then define a rule. Rule number one, place of birth relates a person to a location. So that statement tells us the entity on the left is actually a person, an entity on the right is actually a location. So we can add, let's say, another arrow to another entity, and then define rule number two. We can say place of birth relates one person to one location. So it helps. So if we have this one, we can infer whether this one of these entities is the same as the other entity, or one is part of the other one. So we call rule one lower bound, and we call rule two upper bound. And so we can actually do prediction. Either these two are the same, or one is part of the other one. So here, for example, this is Socrates, this is Athens, and this is, for example, Greece. So we know Athens is part of Greece. So it's fair to say Socrates has a place of birth, Athens, and we can also say Greece is the birthplace of Socrates. So whenever we talk about semantic, we're actually talking about predictable inference. And the formalism we use to capture this data is called Resource Description Framework, or RDF. So you probably, many of you are familiar with the notion of subject, predicate, object in linguistics, or in for example, natural language processing. So it's for example, so we can say mosquito transmits malaria, and then we can actually use some formal language. For example, here we use RDF XML format to present this kind of, for example, relationship. So these are two concepts related with each other to a property. This is what we call the predicate. We call it a property here, and these are concepts. And so this is formal representation of knowledge. And then we can actually connect malaria to, for example, a medication, for example, and so on. You can actually connect medication to the components. So as you can see, all of a sudden you can capture knowledge about a specific domain through different numbers of, for example, RDF triples. And the number of these nodes and the connection is really depends on the complexity of the domain. And we usually use some logical axioms. For example, people use first order logic or description logics to axiomatize and define this concept and the relationship between them. And so we can, for the rest of the talk, so I'm using mostly the, instead of semantic network, I use the term ontology, which is more formal artifacts in computer science. And we can actually create different ontologies, like, for example, capturing knowledge about diseases, about the therapies, about the medication, molecules, experiment, documents, and these ontologies can be related to each other as well. And all of a sudden, so we have complex, overwhelming, difficult to process, heterogeneous data set packed into a formal, explicit, machine readable, rich, and machine computable artifact. So we can do actually computation over this new product, and we can make the knowledge reusable. So many people can reuse, for example, this shared knowledge or many systems. And then you can define, for example, multiple queries and extract, in order to answer these queries, you can extract, for example, one part of this graph and provide, for example, the answer. For example, you want to see what are the risk factors of obesity and how obesity can, for example, lead to other, for example, complicated condition in downstream. And it can be quite complex. So this is a schematic representation of one of the European projects called Linking Open Data, a LAD project. And so at some point you can see the data coming from different sources, like, for example, the green ones coming from linguistics, the turquoise coming from area of geography, the orange coming from government sources, red from life sciences. So you can see, for example, at this point, we are talking about more than 31 billion RDF graph connected via more than 500 million links. So this is huge. This is huge, and that's exactly what we are dealing in many of the population health and life science problem. The main theory we are dealing with from public health is the notion of evidence-based public health. So that's going to be something we will be using very often in our systems. And based on this evidence-based public health, we have different layers of knowledge. More specifically, 3 types of knowledge. Type 1 knowledge, so these are the knowledge talking about the causality and associations. And type 2 knowledge, these are the knowledge talking about the intervention effectiveness. And type 3 talks about intervention implementation. And another mention of social determinant of health theory and how, for example, we can collect this social determinant of health from individual level up to community and population level. And if you go to, for example, CDC database of intervention, you can always find out, for example, different social economic factors component involved in multiple intervention stored in the databases. And the other thing that we are using, the other theory we are using is the theory of change and automatic intervention evaluation. So in order to change a disease or condition, we need to have a sequence of action and a causal pathway, if you want to call it, from the beginning to the end. And so that would be something we want to automate and show how we can actually start from upstream health risk factor and go all the way down to downstream health consequences. So I show you some examples from different application areas. So we have a couple of systems in both communicable diseases surveillance and chronic disease surveillance. So for example, for infectious disease or communicable disease surveillance, I can start with one focusing on detecting hospital-acquired infections in the hospital setting. As you can see, the hospital setting, so the data comes from multiple locations. Hospital-acquired infection is one of the major problems in hospital and in public health across the globe, specifically in the US, almost 1 in 20 patients acquire this hospital-acquired infections, and it leads to almost 100,000 deaths per year. And most of this infection are not detected before discharge. And so again, you see the data set coming from different modalities. And this is actually the framework we implemented called HAIKU, Hospital-Acquired Infection Knowledge in Use. And we start with building the ontology, with mapping the local terminology to the concept in the ontology. And then after constructing our knowledge graph and ontology, we can actually use a certain number of web services. These are semantic web services. They can be used to populate our ontology with the actual data stored in the data repository at, for example, the hospital. And we use rule definition and reasoning capability to find, for example, different cases. And then we have a dashboard. It can be used for query answering, and the users can actually find different cases and flag, for example, any risk or any, for example, sign of hospital-acquired infection as early as possible. while patient still in the hospital. So this is, again, going back to the concept of RDF we discussed in previous slides. So this is a formalism, for example, we use, this is a more human readable version, for example, from this formalism. And as you can see, the red boxes show the concept and the blue boxes show properties. And you can see, for example, we have a patient and we have a diagnosis, and the diagnosis is performed for a specific patient, and this diagnosis has a time, and so we have the time. This diagnosis identify, for example, an incident, and the incident is a surgical site infection and is a consequence of a surgery. And what is a surgery? It's a coronary artery bypass graft, and it has a time, surgery time, and so we how we actually discover this incident because of the blood culture test. And the blood culture test has a result. Again, we have a time associated to this result, and the blood culture result shows specific findings, and the finding is positive blood culture findings. So we find, for example, an infectious agent, and so we can find it in the taxonomy in NCBI. And what we're going to do, we're going to order medication. We have a pharmacy service here. This is a service for the patient, and it manages a drug product. And again, we have a service time for pharmacy. And at the end of the day, you can see we have a hydrocortisone injection prescribed for this specific patient for this specific condition. This is just an example of how we formalize the knowledge inside the ontology. And this is an editorial, it's a protege editorial to code our ontology. And these are, for example, the place we can actually define each concept and the relationship between them using description logics. And at the end, so we can use this knowledge to generate what we call it electronic triggers to classify different patients under, for example, suspect, confirmed case, and probable case. So this is actually, this can help infectious control agents and quality control agents in hospitals to actually screen different patients for hospital-acquired infections. So we do have another project called Semantic Interpretability and Evolution for Malaria Analytics. We do have pretty much a similar concept for collecting data from distributed malaria sources. Many of them are located in different, for example, geographical location, some of them in North America, some of them in Sub-Saharan Africa, and they are stored in different modality. And so we use the same platform for malaria to improve malaria surveillance. And the third system actually is called PopHR. And this is what PopHR is pretty much like an EMR for individual, but this one is for population. It's population health record. And it intended to be a semantic web-based platform to integrate and analyze and visualize population health data in a specific geographical location. And a major emphasis on all this PopHR and population health observation and surveillance is focusing on addressing the problem of disparity. And while taking for example from COVID, you can see that disparity in testing, you can see disparity in vaccination, you can see the disparity in, for example, number of deaths. So the disease is not impacting all segments of population equally. So more vulnerable population, minority, people belongs to lower social economic class hit harder in this pandemic. So we have more number of hospitalization. We have disparity in testing, vaccination, illness, and all that. So we did really interesting studies on the link between social and economic and environmental disparity and how it leads to disparity in health outcomes. Dr. Sheen specifically did an amazing job looking at different diseases and conditions and looking at the link between neighborhoods quality with different, for example, diseases outcome. Asthma, for example, was one of them, and also the cluster of chronic conditions in the city of Memphis. So we know, and it's not very surprising, so the literature actually confirmed this findings. So there is apparently a strong association between social, economic, and environmental stability with disease outcome. So based on all this finding, we are implementing what we call it Urban Population Health Observatory, or UFO. And so this UFO has the capability to monitor, for example, different type of condition and diseases. It can do COVID, for example, surveillance. It can do chronic disease surveillance as well. So I'll show you some examples for COVID surveillance. The UFO architecture consists of different, for example, segments. So we start with the data management layer, which consists of, for example, different data set coming from individuals coming from population. So some of them are linked to social determinant of health. And we have a knowledge and intelligence layer, which has two subsections, analytics layer and semantic layer. The analytics layer is talking mostly on the data and how we can link this data together, how we can integrate this data, how we can geocode, for example, this data, and how the explainable models can be built. And then we have a semantic layer. So this semantic layer is mostly focused on creation of the ontologies and the knowledge graph, performing reasoning, automatic inference, and finding new knowledge out of the existing data set. And at the end, so we're having a dashboard. This is an application layer, and it's a GUI, graphical user interface, very adaptable based on different types of user. If it's a novice user, it's an expert users. If it's, for example, a public health decision maker, so it can adjust itself based on, for example, different user expertise and needs and requirements. So, for example, this is one example of use case for this application, how we can show spatial distribution, geographical distribution of, for example, different conditions in city of Memphis in the United States. And so here, for example, the condition of interest is COVID, and you can see the number of, for example, testing has associated with the social economic status. People with lower social economic status has lower availability of testing. And so you can now actually define the timeline, and you can define, for example, different geographical location, and based on your setting, you can actually get information about one region and check the trends of COVID in that specific, for example, location. And so we can actually provide justification about this color coding. So we can say this color code shows the risk level. If you are, for example, clicking on a dark area, so it shows the risk level for traveling to this area is high. And for example, this is specific county, for example, this is a very unusual region. So that for 14 days, for example, analytics, the positivity rate was quite high. Almost half of the population tested for COVID were positive. So you can actually use this data and send some recommendation. For example, avoid unnecessary travel to this region, or for some COVID prevention strategies, we can actually guide the user to appropriate links and websites. And here you can actually do some causal analysis. These are the concepts in the ontology, if you remember. And when we populate this concept with the real data, so you can see different colors actually linking different entities with each other. And for example, the blue, the solid blue shows a strong positive association between for example, nodes, and the dotted blue is a big association. The solid red shows strong positive association, strong negative association, and the dotted red shows weak negative association. So as you can see here, for example, no vehicle has strong negative association with COVID-19 testing here. And for example, occupied housing density has strong positive relationship with COVID. Okay, and then we can do some interactive time series analysis here. So we can stratify a model based on age, gender, and race. So we can choose different time frame. So we can actually specify an intervention of, for example, interest, for example, what's happening after the policy related to shelter in place and a school closure. So you can actually do some intervention impact analysis here. And the last system I'm going to talk about is the system related to surveillance of adverse childhood experiences. And so this is actually an explainable AI recommender system that helps social worker and healthcare provider interviewing with patients and identify the problem and refer them to appropriate resources, and also make equitable resource allocation. So this is some example of adverse childhood experience. This is the major health crisis in the world, specifically in the US. There have been a lot of attention to these conditions through the past couple of years. So we had more or less 10 conditions: abuse, neglect, familial violence, mental illness, parental separation, divorce, and etc. So these are adverse experiences children encounter at a very young age, and they leave the marks on the kids and their health and well-being way over the adulthood. And it can link to a lot of health adversaries, even early death in the older age. So we actually created adverse the childhood experience ontology. We deposited into bioportal. It's freely available if anyone wants to use. And so these are the major data sources actually in different modes. It can be actually the data can be captured to live question answering. It can be captured to recorded, for example, question answering. And as you can see, so here is, for example, a simple clinical node. So it can be tokenized using natural language processing techniques. And we use ontology to annotate each and every concept. For example, 2-year-old, it means it links to an age in an ontology, or male links to a gender in ontology. And for example, this 38127 zip code has certain, for example, characteristics. So we know, for example, this is a lower social economic status neighborhood, and it comes with a lot of different risks. And at the middle, we have a knowledge graph, and at the end, we have some quantitative analysis and statistical analysis component. And as you can see, we can actually create a large knowledge graph connecting different conditions to each other. For example, if an individual has an income of 20,000, so we know this income linked to his or her social economic status, and social economic status has something to do with food accessibility. And so you can actually track all this different component and this path to knowledge graph and find, for example, different generate different recommendation based on this data. Like, for example, if Alice lives in specific zip code, and this zip code is belongs to a neighborhood with a physical characteristic of, for example, presence of blight or vacant land and distressed houses, and it may, for example, exposes her to toxicant and for example, other chemical, which may lead to asthma. And so we can actually use this knowledge feeding into a recommender system. So we have two panels. One is a question answering panel. The other one is healthcare practitioner assessment panel. In question answering panel, for example, a healthcare provider, it's very much like a chat box. So it goes to a conversation and try to find appropriate keyword, matching it to the knowledge base, existing knowledge, and based on each question, it comes up the follow-up questions. And when the social worker analyzes this, for example, answers, it can determine the number of ACEs, for example. It can, for example, link the patient to appropriate resources. If, for example, lack of accessibility to food is a problem, so they can, for example, refer the patient to food banks near her house, or book a referral to the nearest psychology clinic in her neighborhood. Okay, so in summary, explainable and responsible AI can support inferences about who, why, where, and when question. And also it can give you information about the nature of this knowledge, how this thing's happening, and why this thing's happening. So the classic approach are good answering who, why, when, and where question, but how and why question are a little bit tricky. So these are the questions we try to answer using this method. And we can actually reveal new knowledge. It can lead to knowledge discovery, and the result would be understandable and verifiable. And so there are still a lot of challenges we are dealing with. Most of the challenges come from the privacy of patient and population, stigma for population living, for example, in specific neighborhood, and dealing with the problem of legal and ethical problem, and also ownership of data. So who owns, for example, all this new data set? And I would like to thank all the amazing people, all the members of Population Health Intelligence Lab, both current and current member, and also alumni. They did a wonderful job. And these are some of our collaborators and funding agencies. And I would be more than happy to answer your questions.
Thank you very much for your insightful talk. Utilizing artificial intelligence in health and medicine had shown promising results. But as you can see from the talk, there are a lot of things we actually need to solve, and there are many challenges left to be improved, especially given the different types of data that are available, how to integrate them together, how to make a reasonable and reliable inference from the data, and so on and so forth. So thank you very much, Professor Shaban-Nejad, for wonderful talk. And thank you again for Professor Eugene Chung for insightful discussions and questions. And also, I want to say thank you for our staff, Eunjae Kim, Jin-tae Bae, Subin Song, to whom I owe a great deal of gratitude. This program was not possible without our staff's dedication, excitement, and passion. I feel extremely fortunate to have these wonderful students in our field. 9 weeks ago, we started this KU Global Lecture Series focusing on data in the era of digital transformation by saying, I hope that we will leave this program with enhanced passion to do battle with data and to cultivate an ever richer harvest of insight from data analytics. It is my hope that you have learned through this program was not simply enjoyable, but rather invigorating, tantalizing, exciting, and energizing. So is the field of data science. Most importantly, I thank you all 416 people who joined with us through this journey. I wish you only the best for your journey in the field of data science. Thank you very much.
Thank you very much.
Thank you.